Well, welcome everybody. It's a real pleasure today to welcome Dean Ackman, who is both the Dean of our medical school as well as the Vice President for Health Affairs. And I just wanted to say a few words of introduction about Dr. Ackman. And this is him starting medical school at GW. He learned many things. The only thing he lost in medical school was his hair. He never left GW. So his entire medical career has been at GW as a medical student, then as a psychiatry resident where he rotated here at Children's National, then as a faculty member. And as a faculty member, he developed the first psychiatry program focused on HIV AIDS. Also during this time, he became an expert educator, winning many awards and ultimately becoming Dean of Education at GW. Then he was promoted 9 years ago to become Dean of the Medical School, and during that time has been an incredible supporter of Children's National and all that we do here, especially in the area of education and research. And really, I don't think we could have accomplished all that we have without Dean Ackman's support. And during his time as Dean, this picture really just exemplifies his focus on education, on students, on creating a collegial atmosphere at the university, and one that's been very, very successful at advancing the U.S. News ranking of GW and creating an environment. He came in as Dean when GW was on academic probation from the LCME. He created a new curriculum, and now GW has never been stronger than it has. And as he completes his term as Dean, we really wanted to invite him to come here and to talk about the Dean's view of education. So without further ado, I'd like us all to welcome Dean Jeffrey.
Well, good morning, everybody. It's great to see you. Thank you very much for showing up, and thank you, Mark, for your partnership through this entire time. And the wonderful thing about seeing that very first photo, where it's circa 1981, I'd expect to see AD or something like that after it, but. It's an amazing experience to be the dean of your alma mater, and so I always have felt extremely fortunate and really a great sense of being humbled by that. When you are a student, and I've said on many occasions, and it's always terrific to be here. Children's National is in my DNA. And while I'm not a pediatrician and I'm not a child psychiatrist, Children's has very much informed my deanship. And of course, through education and training, through our work together on faculty affairs and development, the GW tuition benefits that many of our faculty and fellows at Children's use, our strategic alignment on many issues, but perhaps more importantly, as Mark was saying, through research collaboration that's really grown. And it's clear to me that these things had to happen to enhance the value proposition of having GW as a partner for Children's National. And I imagine that with Kurt Newman continuing at the helm with our new dean coming in, Barbara Bass, who is a respected academic surgeon and a colleague and friend, that this relationship will just continue to build and grow and strengthen through the years. So many of you know my history. I'm just going to very briefly tell you as it relates to children's. And plus, I want to reminisce a little bit. So most importantly, for all of you on the faculty, thank you. Thank you for your support of the GW School of Medicine, Health Sciences. Thank you for your support of all of our initiatives. Thank you for your support of me. I am very clear in saying that no dean can be successful without a very strong, vibrant, supportive faculty, and you don't do this without standing on the shoulders of all of those who come before you. You don't one day walk in and create something new out of whole cloth. And so all of the previous deans, all of the previous vice presidents are part of any successes that occurred during my tenure. And of course, a major reason that we do this is for our students and our future colleagues who are here as students, as residents and fellows, and the vibrancy and the energy and the inquisitiveness and the curiosity that they bring to our lives. So I want to thank all of our faculty and our students and everything that you've done to support the mission of the School of Medicine and Health Sciences. So that photo, if it was circa 1981, it must have been more my graduation photo rather than my starting photo, because I started medical school here in 1977, which means my third year pediatrics clerkship was in 1980. I remember very well because I was on the infectious disease service with Dr. William Rodriguez, who was running service in those days. I remember doing a lot of spinal taps on infants. That was it was a lot of H flu, meningitis, and I learned a lot. I learned a lot in those days. And Dr. Muriel Wolf was running ambulatory pediatrics, and we would meet with her on a regular basis and learn about peds from an outpatient perspective. And then my second month on peds, I was in the adolescent clinic with Dr. Tom Silber, who even then was recognized as a leader in the field of adolescent medicine. So I had this really amazing experience in pediatrics. That was in 1980. And I went to the dean at that time, Dr. Timowitz, when it was time to find out what I was going to do for my fourth year and what I was going to go into. And we had a wide-ranging conversation. I said I was interested in peds and I was interested in psychiatry. And he said, well, psychiatry, where did that come from? And I told him blah, blah, blah. And said I like to spend the time with patients. I've done a lot of reading in the field, and I like the faculty. And he said, well, why don't you take some electives in psychiatry? Why don't you go back to children's and sort of figure out what you want to do? So I came back to children's for my fourth year, and I combined the psychiatry and neurology. I created an elective, 2-month elective on neurology with Dr. Sam Shelburne, and then in psychiatry with, at the time, Dr. Jim Egan was the chair. And I just got very turned on by brain development in children, but more towards the psychiatry side, and clearly graduated medical school thinking I was going to be a child psychiatrist, especially since the GW psychiatry relationship in those days, in the PG1 year, 6 months in the PG1 year was spent at Children's doing psychiatry. And I thought, wow, I love child psychiatry. I'm going to come back to Children's, and I did. So I was at Children's 6 months of my PG1 year doing psychiatry with a really remarkable group of psychiatrists in those days, including the chair of the adult department, Jerry Weiner, but who was a former chair of child psychiatry at GW, Dr. Joe Noshvitz, Carl Feinstein, and Irene Chatur, and really a very, very terrific department. I'm just unable to mention all of them. And as I sort of went through my residency with an intent to do a fellowship in child psychiatry at Children's, that's when HIV started showing up. And so that was in the early 80s. I was finishing my residency program, and I started hearing about these young gay men who were coming into GW Hospital and dying of this unknown disease, and there was no antibody test at the time. We didn't know what it was. And I started sitting in the patient's rooms, and I started hearing their stories, and really was drawn to this unknown illness that was taking people so early in their lives. It was also a time when I was also in the midst of my own personal transition and was coming out, and so had a very much a personal connection to these young men. It was a period when food trays were being left in halls, when, again, this was in 80, probably, I think the first case was 81, but in district, we were talking 82, 83. The antibody test wasn't discovered until 85. So I remember going back to talk to Jim Egan, Dr. Egan, who was my faculty advisor at Children's, and saying, Dr. Egan, I've decided that I'm not going to do child psychiatry. I'm feeling this pull to learn about HIV and to see if I can help make a difference here. And so I joined the faculty at GW. I was able to get an NIH grant to do early HIV psychiatry, neuropsychiatry work, and that really became an important part of my early career. As I was teaching as a junior faculty member, I was teaching psychiatry clerkship, I was teaching human sexuality, and one of the areas that in teaching human sexuality on the clerkship was where I met Denise Cora Bramble back in the 80s when we had this innovative program. Denise was in the school system, DC school system. I was running the psychiatry clerkship, and we would have our third-year medical students on the psychiatry clerkship who learn how to teach sex education to kids and adolescents in DC public schools. So that actually was a component of the clerkship where Denise and I would get together. We would have this curriculum. We would teach our students, and then our students would go in and they would learn child and adolescent development, but also learn how to talk to kids and educate kids about sexuality. It was a really interesting program, and it created a relationship and a friendship between Denise and I that I'm very grateful for. So, Denise, thank you. And then also around that time, began also to do some work with Dr. Larry D'Angelo and his pioneering work in HIV/AIDS in children. And just an FYI, the Burgess Clinic, the HIV clinic in the HIV and the AIDS and the Adolescent Center was named for a classmate of mine in medical school, the guy faced, Glenn Burgess. So Glenn and I were friends in medical school. He was a pediatrician and unfortunately passed away of HIV/AIDS, and Children named the HIV clinic for adolescents after Glenn, who was a tremendous, tremendous person and a tremendous doctor. I then went and served as chair of the psychiatry department, and the psychiatry department at GW and Children's are very, very closely linked around psychiatry, psychology, and neuropsychology. And the chair, former chair, Paramji Joshi, and now Adelaide Robb and I work closely as well with all of the faculty. So again, this connection to Children's really, was very much a part of my job as chair of psychiatry. And our annual graduation dinner, which we held together at the Cosmos Club every year, was always a wonderful event. But then most recently, as VPHA and Dean at the end of 2010, my relationship with Children's has really just taken a whole nother level as I've worked closely with the leadership of Children's, including Kurt Newman, and, as I mentioned, Mark Badshaw, David Wessel, and Roger Packer, and Denise, and Mary Odolini, and Linda K. Woodford, and Stephen Teach, and Vittorio Gallo, and Naomi Lubin, and Eric Hava Lane and Kath Millard and Terry Kine and Devesh Agarwal, and on and on and on. People who really are so central in this relationship and its continued growth and development. And so for all of you that I didn't mention, I apologize, but still want to thank all of you for this, really remarkable relationship that continues to evolve. So when I first came here, I thought children's was amazing back in the 1980s, right? But what's happened in the decades since is truly stunning. And children's, as you may know, children's employs the largest number of faculty in the GW School of Medicine and Health Sciences, by far, right? So your achievements in providing outstanding clinical care to children and their families, transforming communities, providing superb teaching and the training of students, residents and fellows, and participating in innovative and cutting-edge research is a great source of pride to all of us at GW, and certainly to this team, who really does appreciate all of the amazing work that you do. When I think about the mission of our academic medical centers and academic children's hospitals and all teaching hospitals, it's truly special. It's a very special mission to advance knowledge, to educate and train the next generation of health professionals and physicians, to provide the most advanced and compassionate care to our patients and their families, and to serve our communities. What an incredible force for good we are across this globe when you put together everything that academic medical centers and children's hospitals and teaching hospitals do. It's really remarkable what we do as a force for good. And when you think about the advances that have taken place just in the 9 years, the scientific and advances that have taken place just in the 9 years since I've been dean, first of all, it's impossible to name them all. I mean, the last decade has been an amazing period of innovation and scientific discovery that's affected basic science, translational research, clinical care delivery, innovation at the highest level, technology, and on and on and on. You know, people practicing 9, 10 years ago have seen some just tremendous advances. One small reflection of that is that we changed the name of the basic science department here in Children from one of being called Integrated Systems Biology to the Department of Genomics and Precision Medicine. I see the chair, Dr. Balloon there. So that gives you just a reflection that what we were even calling our basic science efforts in those days was no longer reflective of the work, or adequately reflective of the work that is happening here in terms of the advances in basic science and translational work. But if you just, in my area of expertise in terms of HIV/AIDS in the last decade, if you look at what's happened since I got started in this in the early 1980s, but just in the last decade, and you think about the amazing advances so that we've gotten to the point where not only can we fully suppress the virus through medication, but we've gotten to this point what we call U equals U. Undetectable equals untransmittable, right? So not only have we made this incredible medical advance of viral suppression, but it's simultaneously this remarkable public health advance, so that you're undetectable, meaning you are untransmittable. So that's a remarkable breakthrough, and that's all really been within the last few years. And this is just one of any number of advances, many of which have come about because of academic medical centers. So with all of these incredible advances in clinical care and science, The reality, however, when you talk about headwinds and challenges, the reality is that U.S. life expectancy is declining and has been declining for the last 3 years. Now, we know that a major part of that is the opioid epidemic. And it's worth unpacking that just a little bit to think about why that would be the case. You know, what is it about the opioid epidemic itself? And there are many parts to it. The first thing that always comes to mind when it comes to things like this is stigma. The stigma associated with substance abuse, the stigma associated with mental health, the stigma associated with many of the illnesses that we in fact treat that are based on shame, embarrassment, humiliation, the perception of others about being a whole variety of different thoughts that people have that they project onto people who have certain illnesses. But what happens with a stigma? It can lead to decreased access to care. It can lead to a decrease in funding, which has certainly been the case in psychiatry, mental health, and substance abuse. And it can lead to a whole host of inadequate resources that are brought to bear on a particular problem. It can lead to the stigma itself can affect the people who go into the field, right? So there's a stigma associated with being a psychiatrist that's very much tied to being that you treat people with mental illness. So the number of people going into psychiatry has always been relatively low. The number of people who go in to treat substance abuse has been lower. So we've really got to unpack that, and we really got to address that. Now, over time, the media, the pharmaceutical companies, there's been a lot of work on stigma, and it has lessened to some degree. But it is still a primary issue as to looking at this particular epidemic that's so important as to why, with all these amazing advances in science and research, U.S. life expectancy has been falling. It affects the amount of money that goes into support research to try to understand the epidemic and to develop effective treatments, right? And it affects, on a certain level, our own understanding of how to treat chronic pain or acute pain. So there are all of these issues that really, when you think about how are we going to turn this entire thing around in this amazing time of advances in science, we really have to sort of dig in and understand how something like this is much more complicated than saying, okay, we just got to get the opioids off the streets, you know. And I'm not saying, because I was going to say, talk about the pharmaceutical industry, but it's a lot more than that. It's a lot more than that. And it really is in terms of our own internal house that we need to look at in terms of if we're really going to make a difference in helping our communities deal with this and our patients deal with this epidemic. There are other headwinds out there for academic medicine. Rising costs to recruit and retain faculty and researchers. I'm now on the university's strategic planning committee to develop a world-class faculty. And, you know, this is our ability, our desire to recruit the best or to help build the best, to support the development of our faculty so that they are the best, comes fraught with its own challenges. It's not only expensive, but once you create the best, they're marketable. Other places want them, right? Other places say, oh, wow, there's a shiny object at Children's. I wonder if we can go get that shiny object, right? So on the one hand, of course, we want to create and develop the best faculty in the world. On the other hand, it then becomes increasingly expensive to keep the faculty together. It's a good problem for the individual. It's a big challenge for the institution. So number one, rising costs to build a world-class faculty and to sustain it, and then to develop our junior faculty into world best faculty. One of the things that I think I've been very, very pleased with over the last several years has been our partnership around faculty development. We've really put a lot of resources together into faculty development in a number of areas, around scholarship, around education and training, around research development, around leadership, around mentorship. So these are areas that we've worked very, very hard together on. And from the GW side, it really, in many ways, was children that had taken the lead, and we built on or added on or then collaborated in some of these programs. The rising cost of providing care, which, again, nobody sees an end in sight to that, even with all of the efforts to control costs, it's extremely hard to really control the cost of providing care, and that includes prescription care. So that's a major challenge for us in academic medicine, because as the costs rise, one thing we're seeing is historically there's been a decline in reimbursements, and now we're in this interesting move, in terms of the overall landscape, the healthcare landscape, of moving from volume to value, right? Which in many ways is a much, much more patient-centric approach to providing care, looking at quality, looking at safety, looking at outcomes, which we really hadn't done in the past. Again, in terms of how the world has changed in a relatively short period of time and is continuing to change. So when you think about sort of perspectives on medical education and on academic medical centers, this is an area that's incredibly important. How do dollars come in to support the efforts of our clinicians to provide the complex care in particular that takes place at a tertiary and quaternary hospital like Children's National or any academic medical center? The dependence on federal dollars every year is a big issue for academic medical centers as we fret about the potential for cuts in already very inadequate dollars. The competition for a federal grant is so crazy. I mean, the rates of getting grants accepted is in many ways microscopic. It's microscopic. So to apply 20 times to get a grant funded, it's very, very time consuming. It's very, very expensive, and it's demoralizing, right? So this is another major headwind in front of us, as while there's a lot of support at any given time for supporting the NIH and other federal agencies that support research, and in fact, every year we're challenged by that. We're concerned there are going to be cuts. And indirect costs from federal grants are a major source of revenue into academic medical centers, but more importantly, it provides the fuel that makes us the envy of the world in terms of the research engine that every academic medical center is and every top children's hospital is. And it creates these innovations and these new discoveries. There's another sort of, when I think about what it is that is supporting what we do, of course, tuition. Tuition dollars are crucial to any medical school. And medical schools are getting more and more expensive. It's more and more expensive to do what we do. There's, you have certain fixed costs that even if you were cut so close to the bone, which I believe is what happened in the prior administration before me when the school was placed on probationary status, you can't, it's still a lot of money. It's a lot of money to adhere to all of the accreditation standards that we must adhere to, whether it's undergraduate medical education, graduate medical education, or any of the professional programs that we have amongst us. So very expensive to meet all those accreditation standards. Student indebtedness, medical student indebtedness, has really become a major problem. GW, we've been working very, very hard on this issue, but the average student indebtedness in the United States for medical students at graduation is around $200,000. That doesn't include undergraduate indebtedness. And if it's on average, that means we've got students graduating with $300,000 worth of debt. Some even higher with $400,000 worth of debt. So we've been working very, very hard on this issue. When I first started at GW had a reputation of being either the most expensive medical school in the country or the second most expensive medical school in the country. We've worked very hard to bend that tuition curve and to put more money into scholarships and grants. I say bend the tuition curve because we have not been able to cut tuition. We have not found a donor who's willing to pay to make us tuition free. Although I was talking about that when I first took this job, I was fantasizing with my alumni, hoping there was somebody out there who knew somebody who could make GW Medical School tuition free. We're not there, but we've made significant progress in this particular area. So we were either one or two or certainly three soon after I came on board in terms of the most expensive. We're now the 33rd most expensive. It's still high up there, but there's been a significant, it's one list you do want to go down. So we've gone down that list. We've now we've doubled, more than doubled, our scholarship and grant money for students. One of the areas where we've been successful in philanthropy has been in scholarship fundraising. And so now we're in the top 20 of scholarship and grant money that supports medical students across the country. So we've made significant advances in that area. And when you look at our average student indebtedness, if the national average is about 200,000, we're now down in the 170-some thousand range, still way too high, but we've dropped 40 slots. In the time I've been dean, we've dropped 40 slots across U.S. medical schools in terms of student indebtedness. But it's tough to sustain this. It's tough to sustain this because the costs keep going up. So we're putting more dollars and more support and more scholarship money into our student indebtedness. But this is a national problem for medical education, a national problem. And unless you're Columbia or NYU and have billionaires who can, and who have an interest in making, med school tuition free, it's going to be a continued challenge for the next dean to keep these kinds of costs under control. Another major headwind, another major challenge that everybody is so aware of is our shift. And it wasn't that long ago when my charts were all paper, and of course now charts are electronic. And the amount of administrative time that has intruded into the lives of all health professionals, much of it in front of the EMR, right? And we still have not fully realized the promise of the electronic medical record. There's still a ways to go to be able to fully mine all the data that we know is in those records and to learn how to change clinical care based on the data. But what we're seeing is more burnout, more depression, more difficulties in retention. And when you drill down on that, it's not just the hours, it's the being engaged in time that's not meaningful, right? We get a sense of reward by providing care, advancing knowledge, et cetera. That's what's meaningful to us. If our mission is our North Star, then electronic medical records is like hell, right? That pulling us away from what's meaningful leads to this whole sense of despair, lack, and then ultimately there's plenty of studies looking at burnout. So this is a big challenge for us, and it's something the field's going to have to really wrestle with because, look, I haven't seen, in the GWMFA, we think it's a success to reduce a physician's clicks by 1,000 during the day, right? When you're reducing clicks by 1,000 and you think that's successful, then you still have a lot of work to do, and we do in this area. I want to also talk about how philanthropy has changed, because again, all of these things are happening simultaneously. And one of the biggest issues about philanthropy is how donors, whether they are socially conscious or much more sophisticated, the gifts are increasingly restricted, narrowly focused on the donor's interest. And not surprisingly, sometimes require additional resources by the actual institution to make that gift work, right? We call these gifts that eat, right? So on the one hand, you're like, this is great, I'm getting this gift. On the other hand, you're saying, oh yeah, but I've got to put all this money in now to make this gift do what it's supposed to do. And then, of course, tax laws are changing, and it's still not clear how the world of philanthropy is going to, move forward in terms of some of these tax laws. But we now know all of our organizations can't live without philanthropy. Federal support is not enough. Tuition is not enough. Indirect costs are not enough. Philanthropy is increasingly important in all of our areas. And the competition for the dollar is intense, and the world of philanthropy keeps evolving. So, as we have all of these, there's one more sort of headwind that I just need to talk about and I've talked about this at one of my commencement remarks, and that is, as we have these incredible advances in science and research, we also have these very, very, what Merriam-Webster, this was a few years ago, the word of the year in Merriam-Webster's dictionary, I think it was 3 years ago, was post-truth. So we're in a post-truth era. And what does that mean? I think for us, it means anti-vaxxers. It means taking science and denying it. It means climate change deniers. There's a whole host of areas that people are denying science that then has an effect on patient care and community health. So the anti-vaxxers, and you look at the measles outbreak in parts of New York, right? So this has real consequences. And we don't see this abating. If anything, it's probably going to get more intense as there are more conspiracy theories and other thoughts that are anti-science, anti-truth. And it's not even about being political. I think from the standpoint of health professionals and public health professionals, this is something that is so crucial for us to combat in all of our communities. There's a law in Texas around abortion. And in the law, there's actual lies about. In the law, it states that getting an abortion puts a woman at a higher risk for breast cancer. The perniciousness of the post-truth world has incredible range of negative consequences. So this is really something for all of us as we educate our patients and their families, as we speak to legislatures, as we speak on the media. It's essential for us to keep coming back to the science and the truth. When I look back on what I consider some of the successes of my tenure during this period, I typically go back to the strategic plan that we created soon after I came on board, which included many of the faculty and children. We brought together a very, very large group of faculty and students to come together and work on a strategic plan. One of the things we did was we changed our mission statement in a couple of very important ways. Number one, we included diversity and inclusion in our mission statement. We added advocacy as an important part of who we are as an institution. And we included an aspirational statement in our mission statement about eliminating health disparities, that we accept the challenge of eliminating health disparities. I don't have to tell this group about health disparities. But when you try, again, to unpack all of these issues and the efforts around diversity, inclusion, and then the separate issue around health equity, one of the earliest things that I did when I stepped into this job was I created a task force on diversity and inclusion, which led to a series of recommendations, which led us to opening an office of diversity and inclusion, and then also to creating a deanship in diversity and inclusion, which Dr. Yolanda Haywood has held, who is now our Senior Associate Dean for Diversity, Inclusion, and now Faculty Affairs. She's just replaced Ray Lucas in that position. We also created a number of pipeline programs, as does Children's, with the clear goal of creating a diverse healthcare workforce. I have to tell you, when I look at the numbers of underrepresented minorities entering into the healthcare profession, it's painful. First of all, the number of African American men entering medicine has not changed in 30 years. Right? When I look at the percentage of African Americans going into either the PA profession or physical therapy, two programs that we have, we're talking about 2 to 3% of the African American population that goes into those fields. So when I say, to my PA and PT faculty, what are we going to do to try and get a more diverse student body? It becomes very clear that, first of all, as PA and PT programs expand across the country, which they're doing, the competition for those very, very few underrepresented minority applicants is so intense, so intense. And when you're a private school competing against a state-funded school, you're really disadvantaged. So while we have had significant successes on the MD side, I mean, when you get 12,000 applications a year for 180 spots, you have a shot at creating a diverse class, right? And the last 2 years have been the most diverse classes in the history of the school. The school was founded in 1824, and the last 2 years have been the most diverse classes in the history of the school. We graduate, among all U.S. medical schools, we graduate in the top 10% in terms of numbers of African American medical students. We're in the top 10%, and that includes when you add in the historically black African American medical schools of Howard and Meharry and Morehouse, et cetera. So we've been very, very successful on the MD side. Now, I believe that, again, building on those folks who've come before me, the previous Vice President for Health Affairs was Skip Williams, who was the first African American Vice President and Dean in the history of GW Medical School. Actually, Barbara Bass will be the first woman Dean and Vice President in the history of GW. I actually, while I look like I might not have much diversity as a white man, I was the first openly gay Vice President and Dean. So we've had this series of interesting diversity in these positions. But I believe that one of the things that's helping us in terms of our diversity efforts, not just that we have strategically made an effort on the front end, on the admissions end, but that we've also strategically made an effort in terms of our curriculum and our programming, whether it's around our community and public and urban health track, whether it's around our clinical public health curriculum. But we are trying to differentiate ourselves. And Dr. Batchel mentioned about the curricular revision. An important part of that revision was, how can we take advantage of being in Washington, D.C.? How can we leverage our location in a way that no other medical school in the nation certainly can do, but no other medical school in Washington, D.C. does, right? So I do believe that while we do an enormous amount of work on the front end, I also believe that our programming, meaning the curriculum, is also critically important. And then the support that we provide, and our efforts around recruiting a diverse faculty. So we've got now a series of pipeline programs that really go back middle school and high schools, and really targeting and focusing on a diverse healthcare workforce. Because there's plenty of data to show that just putting up a hospital in a neighborhood is not going to change the health disparity, the health inequity. So an important part is to create a diverse healthcare workforce that's going to work in the neighborhoods, in the communities where the health disparities exist. So that's an important goal of ours. And I know it's really also a very important strategic effort at Children's. We built a Rodham Institute, which is an institute that specifically is focused on education and training around health disparities, and bringing students and residents into the communities and working with our community partners around health equity. And now GW Hospital has been in negotiations with the D.C. government around potentially building a new hospital in Southeast D.C., which in and of itself is not going to be the answer to health disparities. It's an important step because access to care especially high-level care, is really it's really terrible. And patients in Ward 7 and 8, on the adult side, they leave Ward 7 and 8 to get their health care. Okay? So we need to have readily available, accessible, high-level care, but you have to create partnerships with the entire community and the churches. One of the more interesting and successful programs that we developed was with the Pennsylvania Avenue Baptist Church around providing health screening and a partnership with the school to provide on-site health care at the church in Southeast. So there are successes here, but there are huge challenges in front of us as it relates to the low numbers of underrepresented minority students. I talked already about recruitment, retention, and development of our faculty. And we've worked very closely together on this issue in terms of capacity building for our faculty in any number of areas. But again, when you really look at it, where the costs and the concerns around burnout and wellness, again, these are areas that we really have to work very hard on. And then finally, I just want to wrap up talking a little bit about research. So research is the one area that I really felt that we had to step on the gas in a significant way to enhance our value proposition as a partner to Children's. Children's research efforts have been significant and for quite a while in recruiting top scientists, developing great science, and GW really was behind for a number of reasons that are not worth going into. But in our strategic plan, it was clear that we had to make significant investments in research. An important part of what we did was a lot of our investments were strategically aligned with children. Right? We can't do everything. right? We can't do, we have money, but that doesn't mean you can do everything. So we had to be strategic. So that includes neurosciences, it includes immunology, it includes cancer, it includes autism, it includes several areas where we have been aligned. It includes partnering in the CTSI. It includes HIV/AIDS, right? It doesn't include everything because we can't afford everything. But when you're thinking about how do you utilize your resources, you have to be strategic. And one of the things about our strategic plan, it was a roadmap for me on how to spend our resources, which is what you want. You want a strategic plan that says, Dr. Ackman, you are not going to spend those dollars on whatever it is because that's outside of your strategic plan and you don't have enough money for that. And we didn't. We made hard choices, and where possible, we truly did try to align with what our partners at Children's were doing. When it made sense. So what's happened is we're starting to see some of the biggest grants we've ever gotten in the history of the school. We recently got a $22 million grant from on a biobank for HIV and cancer, and I believe from the school's perspective, it could be the highest grant ever by one of our women faculty. I mean, it's possible. I go back far, but I don't know if that's the case. But Sylvia Silver got that grant, and we have more PIs funded. We have more grant dollars, awards than ever. We have more applications going in than ever, and we've seen significant increases in these areas. And it's continuing to grow, and we're attracting stronger graduate students who are in the children's labs. We're seeing more medical students on the front end who come into medical school with research in their background, who want to stay in academic medicine. We're seeing that students who come in with significant research on the front end and then who go into our research track are much more likely to pursue professions in academic medicine. So we're moving that curve. We're changing that curve. Now, we still have a ways to go, and there are challenges in front of us to continue to that ascent, and a big part is our organizational structure and how clinical dollars flow into the school. That's another story for another day. Okay, now finally I'm going to wrap up and talk about what we've done together in terms of medical education, because in the last decade, things have really changed dramatically in terms of medical education. As Mark said, we revised the curriculum. And again, children's folks have been so involved in that, not only to give you guys a shameless plug, your pediatrics clerkship is far and away the most highly rated clerkship amongst our students, but it's also more highly rated nationally than almost all other pediatrics clerkships. So congratulations. What you're doing here in terms of teaching medical students is really at top level nationally. And our students really do appreciate it, and I really appreciate it. But we work together to totally sort of blow up the curriculum into now an organ-based integrated curriculum where we don't have an anatomy course or a biochemistry course. And it's all based on organ system. It's all integrated. We've reduced the amount of lecture time. We've started clinical clerkships earlier. But we have a huge problem. We've integrated what I call clinical public health. We've developed all these additional tracks, including an interesting track on innovation and entrepreneurship, where one of our groups of 4 women medical students just finished second in a new venture competition on asthma technology, where their mentors was Stephen Teach and folks from the DC Impact team to help detect mold and other allergens in the air. Very interesting technology. They went up in front of like a series of Shark Tank, competition, and these 4 women medical students so poised and came in second. So we were very, very proud of them. And that, hopefully, technology will continue and maybe will become the beginning of a company for them. evaluating competency, entrustable activities, milestones. All of those things have changed in the last decade. How we evaluate our residents, how we're going to be evaluating our medical students, it all continues to change. But the one area that has to change, and that's the USMLE, and the impact that the USMLE is having on the medical education of our students and on our residency programs. We are now in a situation where the tail is wagging the dog. This exam, especially step one, which was never meant to have the impact and the force that it currently has for our students and our residents, is now totally out of whack. It's totally out of whack. Our students need to spend so much time preparing. The stress is so intense in terms of what the score means in terms of being able to get a residency program. So I've been a voice at the national level to try and make this pass-fail, to try and make the USMLE pass-fail. I don't think that a residency program, and I think that most residency programs know that those three numbers on a USMLE are not going to tell you that this person's going to be your best doctor. We know that. But now, because the students have so much anxiety about that score, they're applying for all of these, residency programs. The residency programs are overloaded. The students are spending tons of money, applying to all of these programs, all because of this one score, right? Or now two, sort of step two. And it's really an unsustainable issue. And more importantly, one of my chairs said to me one time, Jeff, I'm finding that students aren't reasoning clinical. They're not doing clinical reasoning as well. Now, we spend an enormous amount of time in our curriculum now on clinical reasoning. So I know our students, in fact, are much, much better at clinical reasoning than ever before. But I said, you know what? You don't even look at that. In your residency application interviews, the first thing you look at is the board score. And you screen everybody out based on those 3 digits. So how do you know, right? If really all you're looking at, the first thing you're looking at is what the board score is, then don't tell me about clinical reasoning because you're not even evaluating that, right? So this is a serious problem. I'm not sure where it's going to go. There is serious talk nationally about making USMLE step one at least pass-fail. But I can tell you as a dean, we end up putting so much time and effort in something that I believe does not have the value of the 95% of the rest of the curriculum in terms of how we educate and train physicians. So it's not what I'm going to be working on my sabbatical. It's not a life passion that I work to make this SMLE pass-fail. But it is something that's happening nationally, and I hope that, in fact, we do get that done because it creates an enormous amount of stress for our students, enormous amount of stress. It's unnecessary. It's really unnecessary. Anyway, I think I'm probably in my time, but let me just see if folks have questions or for me. Yeah.
But there is a reception, so I encourage everybody to join us in the reception. Where's that? 1.5.
But while Jeff is here, I wanted to just make a couple of comments. One is around our organizations. And, we're coming up on our 150th birthday next year, which puts us as the 4th oldest children's hospital in the country. But it's a little humbling to think about George Washington starting back in 1821, I think.
Yeah.
So the university will be celebrating their 200th birthday. And then the School of Medicine, one of the oldest schools in the country, I think was 1824, 1825.
Yeah.
So George Washington is historic, and back to philanthropy, I think it was founded by a philanthropic gift by George Washington himself.
Yeah.
So, the themes that Dr. Ackman has talked about, these are rooted deep in history and tradition. And I think one of the great traditions and relationships that we've enjoyed as a hospital, as an academic medical center, is our academic relationship with George Washington, with faculty, students, the research, and all the programs that Jeff has talked about. On a personal level, I think you were appointed just before I became CEO of Children's National. And that was, for me, 8 years ago. And all the things that you heard Dr. Ackman talk about in his own personal career, the excellence, scholarship, the work he's done, all the achievements as a faculty member, chairman, and now as dean and vice president. We could talk about all those achievements, but what stands out to me is his being a role model. And that was evident to me as I looked at being a leader, someone I wanted to emulate. His humility, and it's up there on the slide, was inspirational. The way he looked at things, his kindness, gentleness. But deep inside of that was his courage. His courage to come out as being the first openly gay, probably chairman of a department, and then vice president and dean of a medical school, a world-class medical school in Washington, D.C., and tackling the tough challenges. That's a very important ongoing lesson in our personal relationship, as he quietly and in his inimitable way with grace helped lead an organization in many ways back to greatness. And I think George Washington School of Medicine is on a trajectory of greatness, and it's why we're so proud to be a partner. And, just the little things, for example, personally, inviting me to address the medical students at graduation. Just an incredible honor for me as a new leader. And I could just go on and on. And then the courage to let Children's National, in a way, be who we are. We have a terrific relationship, and we have the freedom to tackle things in many different directions that in an ordinary medical school relationship, a children's hospital like ours might not have. And a singular example of that is our pursuit of creating a new research and innovation campus at the old Walter Reed Army Medical Center. By the way, Walter Reed was on the faculty of George Washington School of Medicine, and when he discovered the source of yellow fever and all the great work he did in the Army. So there's a great tie there. So I'm not going to go on and on, but I just wanted to give you a taste of the important relationship that I've had personally with Dean Ackman, but also that the Children's National, get the name right again, Children's National Hospital enjoys with the School of Medicine. And I personally have been proud to be a faculty member for almost 34 years now. So we look forward to working with Jeff in his new endeavors. I hope that he'll be a frequent participant in everything that we do here at Children's National. And I certainly will look to him for continued guidance and mentorship. So thank you all, and we'll see you at the reception.